Hey everybody, Chris here. Today I'm going to take you through my case study. My case study patient had head and neck cancer. So let's get started and dive in. What's on deck? I'm going to give a little brief overview of cancer, talk about normal cells versus cancer cells, go through some statistics, risk factors, signs and symptoms, complications, different treatment modalities, MNT, touch on a little bit of emerging research, and then we're going to get into the actual case study for Mr. C. So let's get going here. So cancer. Cancer is essentially characterized by uncontrolled cell growth and division. There's a mutation in a cell's DNA during the cell cycle, and that mutation is going to result in uncontrolled cell growth and division from that cell. That mutation is going to proliferate from cell to cell. There's a potential for the cancerous cells to spread or metastasize throughout the body. These cells are very invasive in terms of they take up space and can destroy proper function of healthy cells and organs around them. And cancer cells are very evasive of the immune system. The specific type of cancer that I'm going to talk about today that my case study patient was diagnosed with, and we'll get to that more later, is squamous cell carcinoma. Squamous cell is the thin, flat cells found in the tissues of our skin, the lining of our hollow organs like the stomach, gastrointestinal tract, intestines, and respiratory tracts. A carcinoma is a cancer that begins in the skin or tissues lining our internal organs. So when you combine the two, you get squamous cell carcinoma. A little bit about normal cells versus cancer cells. Normal cells grow and divide as the body needs, whereas a cancer cell is characterized by uncontrolled growth and division. Normal cells undergo pre-programmed cell death, whereas cancer cells survive when they should die. Normal cells are very specialized, whereas cancer cells have no specific role in the body. Normal cells operate within a certain boundary. Cancer cells don't have boundaries. Normal cells are sticky, meaning they kind of stay in the same place, whereas cancer cells have the ability to spread or metastasize. Normal cells are very similar in size, and cancer cells are much more variable. Normal cells also undergo necessary angiogenesis, meaning that the blood supply is brought to these cells when it's needed. And cancer cells, these cells don't need a blood supply, but they do force healthy normal cells around them to provide them with a supply of blood and nutrients unnecessarily. So some basic pathophysiology of cancer. All the way to the left, you have your normal cell. Once that cell has undergone some kind of mutation in its DNA, it enters a hyperplasia stage where the number of cells rapidly increase. So that's the uncontrolled cell growth and division. And then after that uncontrolled cell growth and division begins, you get your atypical hyperplasia where the cell sizes and shapes are starting to become abnormal. After that, you have your carcinoma in situ, which is essentially a grouping of abnormal cells. And then once that group of abnormal cells continues to proliferate, grow, and expand, it has the potential to be microinvasive and metastasize and spread throughout the body's blood and lymphatic systems. So a little bit of statistics about oral cavity and pharynx cancers. These are 2017 estimations in the United States. So these are the most up-to-date estimations that were made prior to the year 2017. It was estimated that in 2017 there would be about 50,000 new diagnoses of oral cavity and pharynx cancers and about 10,000 related deaths. These don't make up a huge percentage of all cancer diagnoses and cancer-related deaths in the country, but these are very severe cases that need to be monitored very closely. It was estimated in 2014 that about 350,000 people were currently living with oral cavity and pharynx cancer. And this type of cancer is most common in people age 55 or older. More men, when compared to women, are diagnosed with this type of cancer. More white men are diagnosed than any race or gender combination. And Black men are most likely to die from this type of cancer. So cases by stage and a 5-year relative survival rate based on the stage of based on the stage that the cancer was in upon diagnosis. Looking at the left here, 30% of all diagnosed oral and pharyngeal cancers were localized upon diagnosis, meaning that they were in one specific area. 47% were regional, meaning that they had expanded to the lymph nodes in the area. 19% were distant, meaning some metastasis was present, and 4% the staging was unknown. And then looking at the bar graph on the right, the 5-year relative survival based on when the cancer was diagnosed looks kind of how you would intuitively think it would. If the cancer is localized when you're diagnosed, you're going to have a higher chance of survival, versus if it's metastasized, your chance of survival drops off pretty drastically. There's almost a 15% drop off when you look at 5-year survival when diagnosed when the cancer is localized versus distant. So moving on to some risk factors and signs and symptoms. Risk factors for developing any kind of oral cancer include tobacco use, alcohol consumption, HPV, GERD, which chronically could develop into Barrett's esophagus, any kind of workplace radiation to the head and neck, being an older individual, being of male gender, and having a poor diet. Some signs and symptoms to look for are white or red patches on your tongue, a combination of white and red patches in your tongue as well. Any kind of oral sore that doesn't heal, loose teeth, a lump on your neck, difficulty chewing or swallowing, change in voice, and unintentional weight loss. So potential complications that can occur in patients that are diagnosed with any kind of oral cancer include unintentional weight loss, muscle and fat wasting, any kind of inflammation of the mouth or GI tract that results in inflammation and ulceration. We also have dysphagia, we have dry mouth, lockjaw, anorexia, poor dentition, and then there's a high chance for infection. Now we're going to look at a few different modalities for treatment. We're going to look at 3. We're going to talk about chemotherapy and radiation and surgery. Those are the 3 primary treatment modalities. Chemotherapy is a drug-based treatment. They target cells at different phases of the cell cycle. Specifically, they target cells that grow rapidly. So they don't target cells that have less turnover. So typically, cancer cells are going to have very high rates of turnover. So chemotherapy targets cells that are rapidly turning over and growing and dividing at a rapid pace. It's systematic, meaning when you take chemotherapy medication, it travels around through your whole body, so it doesn't discriminate. But as I said, it does target cells that have a higher rate of turnover, more so than ones that have a lower rate of turnover. But it can affect all cells in the body. It can affect your hair, it can affect your nails, because those, just like cancer cells, are cells that rapidly turn over. Your hair and your nails grow very fast. Cancer grows very fast. So it's common to see side effects related to the hair and the nails when it comes to chemotherapy patients. And as I said, it's given in cycles. Radiation is a localized therapy targeting a specific area. It causes damage to cells and prevents further growth. That's more of a daily treatment. Chemotherapy is given like once, it's weekly, bi-weekly, once every 3 weeks, 6 weeks, whereas radiation is like every day for 3 to 6 weeks, something like that. Side effects for both of these are very similar. Nausea, vomiting, constipation, diarrhea, weight loss, lack of appetite, pain, and difficulty chewing and swallowing. That's more so the radiation than the chemotherapy. And then also with both of those, there's a high chance for taste change. Specifically, you become much more sensitive to a metallic taste. Utensils, like metal utensils, can become unpalatable to individuals. And then certain meats can also become unpalatable, as there is iron and zinc in a lot of in the meat that we eat. So you might notice an increased sensitivity to using metallic utensils or when your patient eats meat. And then looking at surgery, surgical interventions really are the physical removal of a tumor and the surrounding tissue. Most cancer patients are going to have some type of surgery. and it's usually preceded or followed by another treatment. So you're going to get chemo radiation either before, after, both. And it may result in the need for reconstruction. And we're going to get into something here in a little bit, my case study, where there was some pretty radical reconstruction done on this patient. So what can we do as dietitians? Getting into the medical nutrition therapy aspect of it, MNT is very individualized from patient to patient. We have a good starting point that the Academy of Nutrition and Dietetics recommends, 30 to 35 calories per kilogram of body weight and 1.2 to 2 grams of protein per kilogram of body weight. And then after surgery, that the calorie recommendation does increase, and to provide nutrition support when indicated. So if you have some kind of radical facial reconstruction surgery, you're not going to be able to eat anything PO for a while. So getting a prophylactic PEG, educating the patient how to use the PEG, and providing them with a adequate nutrition regimen is very important for these individuals. And the primary goals that we have are to maintain and improve nutritional status, maximize the quality of life, facilitate independence in these individuals, allow them and train them to self-feed so they can have that independence, and also to manage symptoms as they come across. We don't want them to manage symptoms by themselves. We want to regularly check up with these patients, see what kind of problems they're dealing with, and make recommendations to maximize their quality of life. That's really what our role is. So let's take a look at some emerging research, and this is more so emerging research in elective surgery. There hasn't been much research in terms of patients who have undergone these surgeries in terms of what I'm about to talk about. But it's very important to avoid fasting, or some of this emerging research rather, is mainly focused on mitigating post-operative catabolic metabolism and the increase in our stress metabolism. So following some kind of traumatic event, surgery, burn, or whatever, the stress metabolism is ramped up. There's an increase in cortisol, glucagon, epinephrine, norepinephrine, and the increase in all of these things results in an increase in gluconeogenesis, an increase in lipolysis, water retention, proteolysis, and all of that in combination can lead to immune suppression, hyperglycemia, and insulin resistance. So some of the research to mitigate postoperative catabolic metabolism and reduce the rise in stress metabolism is showing us that we can feed clear liquids with carbohydrates to individuals up to 2 hours preoperatively. And you can give solid foods up to 6 hours preoperatively without risk of aspiration during anesthesia. And the numbers of carbohydrates is you give up to 200 grams of carbohydrates the evening before and 50 grams of carbohydrates, excuse me, up to 2 hours before. And what this does is very similar to a marathon runner when they're carbo loading before a race. We're maximizing glycogen stores. We're putting them in a fed state. We are preventing their body from being in a fasted state prior to surgery. And what that does is it mitigates the postoperative catabolic metabolism because we want them to return to an anabolic state as soon as possible to heal, recover, and improve their quality of life as soon as possible. So more research is definitely needed in terms of non-elective surgeries, but this is pretty awesome. Carbohydrate loading is a big thing when it comes to any kind of radical surgery. There even is research out there about mothers who, before childbirth, starting to carbohydrate load prior to childbirth to maximize those glycogen stores, mitigate the postoperative catabolic metabolism, and maintain proper nutrition before, after, and during. So let's dive into my case study. This is Mr. C. Mr. C is a 55-year-old white male. He was admitted to Central Prison 23-hour hold on November 30th. 23-hour hold is an area in the prison that was designed for inmates coming to receive some kind of endoscopic procedure who are required to be NPO from midnight the night before surgery. So they come into 23-hour hold. strict NPO policy, and it's just a good way to monitor that NPO status. However, 23-hour hold has recently kind of turned into an overflow area of sorts just because of overcrowding. So Mr. C was brought to 23-hour hold and was awaiting a bed on the acute floor in the hospital at prison. His chief complaint was a painful, odd-shaped growth on the floor of his mouth. He hadn't seen any medical providers yet, and he was presented to Central Prison with an unspecified lesion of his oral mucosa. And the reason why he was brought to 23-hour hold wasn't because of him complaining about what the mass that was growing in his mouth. It was because he wasn't taking his hypertension medication when he was in jail. And so he was refusing to take his high blood pressure medication. So he was brought to Central Prison to be monitored more closely and to make sure that he started to take his blood pressure medication. But then this painful, odd-shaped growth was presented to the 23-hour hold provider, and it kind of spiraled from there. Sorry about that. Alrighty, so upon admission, his vitals, just making sure I was on the right slide there, his vitals, normal temperature, pulse, respiratory rate, and oxygen saturation. His blood pressure, based on the new hypertension guidelines, 152/1/4, classified him as hypertension stage 2, which was expected because he was brought there for not taking his blood pressure medication. Anthropometrics, 5'8", 173 pounds, BMI at 26.3, so he was overweight, and he was 112% of his ideal body weight. Labs, when he was brought in, he had a urinalysis performed. Everything was normal. And when you look at all those results, color yellow, he was hydrated, glucose, bilirubin, ketones, protein, those things were all negative, indicating that there wasn't any presence of a UTI, no liver damage, and he wasn't an uncontrolled diabetic. He was properly hydrated, and his tests for syphilis and HIV came back non-reactive or negative. And on the 1st of December, when the provider had an opportunity to see him first, because he was brought there in the middle of the night on November 30th, the provider saw him the next morning, diagnosed him with hypertension, and an unspecified lesion of the oral mucosa, and there was a consult requested for a local ear, nose, and throat physician to perform a CT scan on his mouth to see what was going on with that growth. On the 5th, he went to the ear, nose, and throat provider and had a CT scan with contrast performed. What they discovered was a poorly marginated mass along the anterior floor of his mouth abutting the mandible. So it was poorly marginated, meaning there wasn't any clearly defined perimeter around it. So they didn't know how far it had spread. It was 2.5 centimeters in size, so roughly an inch. And it was involved with the right side of his tongue and the sublingual space. There was also a hyperdense mass-like appearing structure on his right tonsil that was approximately 1.7 centimeters in size. He had mildly enlarged lymph nodes, which meant that this was a more regional discovery of cancer than a local discovery of cancer. So he was a little bit more advanced. We didn't catch it as early as it could have been caught, but it was regional. It didn't appear to be metastasized. And he had a biopsy scheduled for 12/14, so December 14th. The ENT recommended he go see an oral maxillofacial surgeon to have a biopsy on these masses that were discovered. So on the 7th, we received a phone call from the provider in 23-hour hold saying that Mr. C needed to see a dietitian. He was having a little bit of trouble eating. It was painful chewing and swallowing. He was having difficulty eating the regular diet, which includes fresh fruits and vegetables and whole meat. So we went to go see him. When patients are brought to 23-hour hold, we don't see them unless the provider calls us. When they arrive in the hospital, we see them within the first 24 hours. But in 23-hour hold, it's a different story. So if they call us, we see him. So the provider called us. We went to see him. His past medical history includes hypertension. He had a right-sided nephrectomy in 2007. He was on lisinopril at this point in time, so he was back on the medication. He was allergic to penicillin. Mr. C was arrested on September 28th and had been in jail in a different part of the state since then. single with no children. He lives in rural North Carolina, and he used tobacco and alcohol for over 30 years. He said he smoked over 10 cigars a day and has been an alcoholic for a large portion of his life. And the combination of tobacco and alcohol together is the most potent combination and increased. When you combine those two, you have the highest increased risk for developing any kind of oral cancer. So that's a pretty bad combination. Family history: his father died of an unspecified cancer at the age of 86, and there was no maternal history provided. His initial labs were all normal, except his monocytes were a little high and his hematocrit was a little bit high. The monocytes being a little bit high with a white blood cell count of 10.3, so kind of that upper end of normal. Kind of indicated some kind of infection, some immune response going on in the body. And the hematocrit being slightly elevated might have indicated some slight dehydration. And then some subjective data. He had an appetite, but his current intake was pretty poor, related to painful chewing and swallowing that he was experiencing. And he was only able to eat about a quarter of his meal trays, so the softer items on his tray. He had no recent nausea or vomiting. He had a decreased tolerance for the regular diet. His general appearance: he appeared well nourished. He had normal skin color, skin turgor, so he appeared to be hydrated from that test. He had 5 teeth remaining, and when he opened his mouth, he had like a peanut-sized mass on the floor of his mouth, so kind of the size of your thumb, and he was experiencing oral pain. And that mass inside of his mouth was like black necrotic mass with like a noticeable ridge. But it was about the size of a peanut, like a peanut with the shell on it. So objective data: 173 pounds, indicating that his weight was stable for the past 2 weeks. He had been in jail since December, and those were the only weights that we had. So using those 2 weights indicated that his weight was stable, and the other information stayed the same from what I showed you earlier, and he was currently on the regular diet. So his energy and protein needs, based on guidelines from the facility, we didn't know that he wasn't diagnosed with any cancer yet. So we used our acute care guidelines: 25 to 30 calories per kilogram, and 0.8 to 1 gram per kilogram of body weight, and a 1 milliliter of fluid 1 milliliter of fluid per calorie consumed for fluid maintenance. So overall, his recommendations were 2,200 calories, 63 grams of protein, and 2 to 3 liters of fluid a day to maintain hydration. His nutrition diagnosis that I provided at this point in time was chewing difficulty related to oral lesions as evidenced by worsening food texture tolerance. My intervention for him is I educated him on the different types of mechanical soft diets that we provide. We provide a mechanical soft chopped, which all of our mechanical soft diets come with canned fruits and vegetables, so they're going to be a little bit softer than the fresh fruits and vegetables. We have a mechanical soft chop diet where the meat isn't necessarily easier to chew. It's just chopped into chunks rather than provided as one patty. So it's just a less work to cut and prepare that food, but it's not necessarily easier to chew. Then you have your mechanical soft ground meat diet where it's like taco meat sized meats. And then you have your pureed, which is pureed meat and pureed vegetables. So I educated him on the different mechanical soft diets that we had, and he wanted to try the ground meat diet. So that's what we did. And the things I was going to monitor and evaluate over the course of his care was his weight. I wanted him to maintain weight and a healthy BMI. We suspected that it was cancer at this point in time, but we didn't know. But I just wanted to make sure he wasn't losing any weight in case he was going to have surgery or undergo some kind of treatment. I'm going to monitor his modified diet. I want him to maximize his oral intake by providing a diet that's tolerable and that he's able to eat. I want to meet energy, protein, and fluid goals. So those are the 5 things that I primarily monitored and evaluated. Moving forward, 5 days later, this patient was not yet assigned as my case study patient because we didn't know exactly what was going on with him yet, but I was following him a little bit. But the other dietitians were also working on him just for this one encounter. But 5 days later, we received a call from the provider down in 23-hour hold. And the patient was essentially complaining of intolerance to his diet. One of our dietitians received the call, went down to 23-hour hold to meet with Mr. C. He was currently on the mechanical soft ground meat diet. We didn't have a new weight for him at the time. And he had recently been given tramadol. So that's a pain medication as he was experiencing increased pain in his jaw. All of his labs were within normal limits. The energy, protein, and fluid needs remained unchanged from when I had seen him. And he had an upcoming appointment for the oral maxillofacial surgeon to receive a biopsy on the masses in his mouth. The dietitian gave him a nutrition diagnosis identical to the one that I gave, so that didn't change, but the intervention itself did change. He was on the mechanical soft ground meat diet. She switched him to the mechanical soft pureed diet and added 3 Ensures on top of that, just to make sure that if he wasn't able to tolerate the pureed diet or all of it, or he got tired or it was too painful, we wanted to make sure he was getting adequate nutrition in some way, shape, or form. So he was able to drink better than he was able to eat. So that's why we added 3 Ensures, just to make sure he was getting enough calories and protein. So on the 14th of December, Mr. C moved from 23-hour hold to the acute care floor in the hospital. He just moved to the acute care floor, so we had to go see him within 24 hours. I went to go see him at this point in time, and from the time I had initially seen him about a week ago, where the mass was peanut-sized in his mouth, his face had essentially blown up, and it looked like he had a softball on the side of his face, and that wasn't there before. So it was a pretty shocking change, very, very quick. He told me he hadn't eaten for a day and a half. His diet change wasn't processed yet, and he wasn't receiving his Ensure. So we called the kitchen to make sure that he was going to be started on the pureed diet, and we spoke to the provider and made sure that he started to get his Ensure. So his pureed diet was going to start tomorrow, and he started to get Ensure that day. His next formal follow-up was going to be in 4 weeks, and I continued to follow him during that time during medical rounds. So medical rounds over the next couple of weeks, you're going to see that there is a gap there in between the 19th of December and the 2nd of January. That's for Christmas. So during the Christmas week, it was a skeleton crew. So I wasn't there for the medical rounds in between those weeks, but I was there in the weeks that sandwiched it. So for both of those encounters, Mr. C was tolerating his pureed diet really well. There was a noticeable reduction in facial swelling. He had been on an antibiotic for 10 days since the 14th of December. He was receiving and drinking all of his supplements. There was no indication for texture advancement at this time. And on the 19th of December, we received results from his biopsy, and he was diagnosed with having squamous cell carcinoma. So just kind of like a little recap, because I know this is a little intensive here. He was admitted to Central Prison 23-hour hold on the 30th of November because he wasn't taking his blood pressure medication, but he started to complain about the oral mass in his mouth. On the 5th of December, he went to the ear, nose, and throat doctor for a CT scan with contrast where the 2 masses were discovered. On the 14th of December, he went to the oral maxillofacial surgeon for a biopsy. On the 19th of December, the biopsy was consistent with squamous cell carcinoma. So on the 1st of January, this was my formal nutrition follow-up for him. So outside of nutrition rounds, I noticed that there was Mr. C reported reduced pain and swelling in the jaw, and I noticed the reduced swelling as well. He reported he had an increased food texture tolerance. He was currently on the pureed diet. He had lost 1% of his weight over the course of 1 month, which is insignificant but undesirable for somebody who's recently been diagnosed with cancer. The medications he was on were lisinopril for his blood pressure, and he was still receiving the Ensure 3 times a day. All of his labs were within normal limits. I increased his calorie and protein recommendations because of the cancer diagnosis. And he had an upcoming surgery scheduled. So I want to make sure that we were reversing that weight loss. The last thing I wanted him to do was lose weight before going into surgery. So the oral maxillofacial surgeon recommended surgery, but we had to in prison, you have to go through a pretty long process to get approval for a surgery of this magnitude. So we were waiting to find out what the date of his surgery was going to be and exactly what the surgeon was going to perform. We didn't have those details at this point in time. So nutrition diagnosis remained the same because he still wasn't able to progress to a regular diet, but he was able to advance to the ground meat diet. So I advanced him to the ground meat diet, and I also added, he continued with the insured with meals. So over the course of the next 2 weeks, I continued to follow him weekly just because I knew his surgery was coming up and I wanted to make sure that we reversed that weight loss. He was tolerating the mechanical soft ground meat diet very well. He was even eating out of the canteen, ramen noodles, drinking a lot of soda, eating sausage, like breakfast sandwiches and like those processed sausage links that you can get, like kind of a jerky stick type of thing. As I said, he was tolerating the diet very well. Over the course of 1 month, he had a 1% weight gain, which was insignificant yet desirable. However, over the past week, he had lost 3.6% of his body weight, which was severe and very, very undesirable. That's the last thing I wanted to see as he's getting ready for surgery. Surgery's 4 days away and he's losing weight. So I want to reverse that if at all possible. He was on his blood pressure medication. They put him on a stool softener because he was constipated. Likely because of the oxycodone that he was on, limited physical activity. He was drinking a lot of water, so it was probably the oxycodone that impacted that, I would guess, and made him a little constipated. He was also receiving magic mouthwash with lidocaine to rinse in his mouth because it was sore in there, so that provided a little bit of relief. His calorie, protein, and fluid requirements stayed the same. And his upcoming appointment was scheduled for January 29th, and he was going to have a major dissection and facial reconstruction with adjuvant chemoradiation, so chemoradiation after surgery, and he was going to get a prophylactic PEG as well. So I gave the nutrition diagnosis maintained the same, the diet maintained the same. And what I did because of this weight loss is I increased his 3 insures a day to 4 insures a day to try to reverse that weight loss. So he encountered a few bumps in the road after the last time I saw him. 25th of January was when I had seen him last, and he was scheduled for his surgery on the 29th. He missed the appointment on the 29th. The reason was unknown. Because he missed surgery, and they needed to free up a bed in the hospital, he was sent to an outside camp, which is essentially a different prison in the state. He was sent to an outside camp to await the rescheduling of his surgery. On the 30th of January, he had gained 2.2% of his body weight back over the last 5 days since I observed that weight loss, which is significant, very much desired. And he was rescheduled for his surgery on the 8th of January with the oral maxillofacial surgeon. So what I'm going to do now is take you through a few slides to show you exactly what procedures he had done during his surgery. The next 5 slides or so are pretty graphic, so I just wanted to warn you guys about that. First thing he had done was an anterior floor of mouth resection. So he had a large portion of the bottom of his mouth, the front portion of his mouth removed, as you can see in that picture. A little bit of the tongue there as well. He had a hemiglossectomy and tongue replacement, so he had part of his tongue removed and replaced by tissue that was extracted from his neck. So they took tissue from his neck, removed part of his tongue, and then that tissue they took from his neck they used to reconstruct his tongue. And his entire tongue appears to be like this white color as of right now. So we're monitoring that closely as we speak. Tomorrow when I go in, or in 2 days when I go in, I'm going to be taking a look at that just to make sure that it is receiving blood. That's more something that the provider is going to look at, but it's just something to pay attention to as well. He had a mandibulectomy, so the entire side of his jaw, the right portion of his jaw was completely removed. And what they did to replace it was a scapula tip free flap. So that's the scapular portion of your back. He was cut from right along his armpit, down the side of his body near his scapula, and they removed tissue there to replace everything that was removed from his face. In addition, he was given a tracheostomy that he was on. It has since been decannulated before he came back to Central Prison, but he got a trach, and he also received a peg because he's not going to be able to eat for a little bit of time here. So he returned to Central Prison 13 days after surgery, 2 weeks. He was walking around. His wounds looked very healthy. The peg site looked very healthy. His trach had been decannulated. He required regular oral suctioning, especially when you would talk to him. He would very regularly have to go in and suck out some saliva in his mouth. He was able to communicate verbally, but he did use a dry erase board a lot, just because he was getting a little bit frustrated sometimes because he was a little difficult to understand and he had to constantly suction. So he would just use a little piece of laminated paper with a dry erase marker, and that's how we communicated a lot. He did have maintain his sense of smell and taste. And there's a study that I have, one of the 2 papers that I attached to that I gave you guys as a reference, that states that taste is more impacted than smell typically. But he was able to taste, and he was supposed to be NPO, but he said he got some cranberry juice at the hospital and he was able to smell and taste it just fine. So it's pretty incredible that he was able to maintain his sense of smell and taste after such a radical surgery. And I did the little skin turgor test on his hand, and it was pretty poor. There was a lot of tenting there. So I had him do it himself and kind of tell me what he thought about it. So that was something that I was able to kind of educate him on, to be able to monitor himself in terms of hydration status in combination with the color of his urine. So my follow-up with him, essentially, he went through all of those surgeries, everything that I just told you about. He was having postprandial diarrhea, so 10 to 15 minutes after feeding, he was having some pretty bad diarrhea in the hospital because he was feeding him. The nurses were feeding him in the hospital, and he was going to the bathroom 10 to 15 minutes after that was happening. The oral maxillofacial surgeon put him on, said he was made him NPO, and they were giving him that he doesn't remember, nor was it documented, the exact type of supplement he was receiving at the outside hospital. But that's how he was getting his nutrition there. And then our ER provider put him on clear liquids. So you can kind of see the discrepancy there when one is NPO, one's clear liquids. But when I checked on him, he wasn't drinking the clear liquids. He was putting it in through his PEG, apple juice, and milk. So he did experience a weight change at the outside hospital. From when he left prison to when he got back to prison. So outside of our care, he had an 8% weight loss over the course of that month, which is, it's to be expected when you go through some kind of surgery like this, but it's very important to note. The medications he was still on his blood pressure medication, stool softener, the same mouthwash, 2 different kinds of antibiotics, and then a pain medication. His labs remarkably came back as only having high glucose, 126 milligrams a deciliter. And that could have been right after he fed himself, an hour after he fed himself. So I'm very happy with that. In terms of when I was talking about earlier, mitigating the post-operative catabolic metabolism, one of the things that can happen if it's not properly mitigated is you can be hyperglycemic. And having a blood glucose of 126 is really not that bad, seeing everything that this man's gone through. So energy, protein, and fluid recommendations were all based on a combination of post-surgery, a pretty extensive surgery, cancer diagnosis, and I also cancer on treatment. He wasn't on treatment yet, but he's about to go on treatment. So that comes out to about 3,000 calories, 115 grams of protein, and 2 to 3 liters of fluid a day. My nutrition diagnosis for him was inadequate energy intake related to oral surgery, as evidenced by severe weight loss of 8% times 1 month. For interventions, the supplement I chose for him was 2-cal, 6 a day, which provides 2,850 calories, 119 grams of protein, And that should say 2,916 milliliters of water, not 1916. And I chose this formula because it was a dense formula. If I chose a different one, he would have had to feed himself far more than 6 times a day. So I wanted to give him, it was a decision based on kind of quality of life and what I thought was most realistic for him. So I really wanted him to have independence with his feeding. So I asked the nurse if I could grab an insure just to kind of watch, and he hadn't eaten for about a day or so. So I asked if I could get an insure. I got an insure, and I went into his room and I observed him feeding himself. And what he did is first thing he did is he checked for residuals, which was great. He filled up his syringe with water, and he took his plunger and forced the water in very quickly, filled it up with the insure, forced the insure in really quickly until it was gone. And then he finished it off with water and forced that in really quickly as well. He cleaned out his syringe, put the plunger back into the syringe, and just set it to the side. So the recommendations I made was, it's a good chance you're having diarrhea because you're literally plunging all of that liquid into your stomach, and it's a lot of fluid going in there really fast. So I instructed him on gravity feeding in an attempt to reduce the incidence of diarrhea. And I also told him that it was important to keep the syringe and the plunger separate so they can dry a little bit better. Because the last thing that we want is there to be some kind of bacterial growth inside of that syringe itself. And I also recommended the provider order fiber just to try to firm up his stool a little bit as he was having diarrhea. So a little update on where he is now. This is last Thursday and Friday that this happened. On Thursday, he had received 4 cans of his 2-cal. He was feeding via gravity. His bowel movements were normalizing. He was still having a little bit of diarrhea, but it was firming up a little bit. But it was not 10 to 15 minutes after he ate. So the incidence and severity of the diarrhea was decreasing. That was a victory. The fiber was ordered a little bit over 3 grams a day, and there was a consult requested by the provider for him to go see an oncologist to start his chemo radiation. On Friday, improved skin turgor, so he's starting to get more adequately hydrated. Didn't have diarrhea for about 24 hours now, so that was a great success. He was receiving all of his supplements and his fiber. Peg site looked healthy. His wounds looked healthy, and he didn't have any issues at that time. He was independently feeding himself. He was doing really well. So that is my case study. Mr. C had some pretty radical surgery. Here's a list of my references, and then I know you guys can't ask any questions or whatever, but I wanted to show this picture here. This is a 2-year post-op, so that's kind of what his face is going to look like 2 years from now, assuming everything goes well and there aren't any complications. But thank you guys very much for listening. Enjoy the quiz. Thank you very much.